Premature ovarian failure is really a misnomer. It is, in women under the age of 40, better described as primary ovarian insufficiency. The way that one would make the diagnosis of premature ovarian failure would be by taking a history from a patient and finding out that she has irregular menstrual periods and is having fewer menstrual periods than you would expect, typically less than 8 episodes of bleeding in the last year. The more common presentation of patients with premature ovarian failure or primary ovarian insufficiency, the more common history is that they present without having had bleeding for a period of time. Usually it's greater than 4 months. And when we see patients like this and we have a concern that they may have primary ovarian insufficiency or, again, premature ovarian failure, we draw lab tests for them. And there are some specific laboratory tests that help us make the diagnosis. The first is an elevated FSH, and FSH is follicle stimulating hormone. When that level is elevated and is above 30 on repeated measures, and at the same time the estrogen level is low, that is less than 50, we have a strong suspicion that what the problem is premature ovarian failure. There are many differences between premature ovarian failure and menopause. Menopause literally means complete cessation of menses. Women that have menopause are typically, or the average age of menopause is 50 to 51 years of age. Women with premature ovarian failure do not have menopause. In fact, many women with premature ovarian failure, at least 50%, will have some ovarian function that can be recognized after the diagnosis is made, meaning that they may have cessation of hot flashes, etc. We know that somewhere around 25% of women with premature ovarian failure will ovulate, and we expect that somewhere between 5 and 10% of women with the diagnosis of premature ovarian failure can in fact get pregnant. The difference between premature ovarian failure and menopause is huge. Women with menopause essentially are done menstruating. Those women are not going to get pregnant. The most common symptoms that patients have with premature ovarian failure are cessation of menses. Usually it's greater than 4 months where a patient presents and has a history of not having vaginal bleeding. The other symptoms are those of low estrogen levels, and the symptoms of low estrogen levels may be hot flushes, it may be difficulty concentrating, difficulty sleeping, emotional lability, meaning that they may be cranky, they may have difficulty concentrating. Vaginal dryness is another symptom. Difficulty with intercourse and vaginal dryness may be associated with premature ovarian failure. Patients with premature ovarian failure ought to see a physician that has experience in helping patients with that diagnosis, a reproductive endocrinologist or a gynecologist. When we suspect premature ovarian failure, we're going to do an assay for a hormone called FSH, which is follicle stimulating hormone. Elevations in FSH at the same time with low estrogen levels suggest or help make the diagnosis of premature ovarian failure. However, in addition to ovarian function, there are other things that we're going to test for. We need to check thyroid function and adrenal function because patients with premature ovarian failure may have this in the setting of other glands being involved, such as a thyroid and adrenal. As well, patients with premature ovarian failure ought to consider having a bone scan to make sure that they're not already suffering from thinning of the bones or osteoporosis. Patients with premature ovarian failure, there are certain genetic tests that we may want to do to confirm that they're not at risk for rare forms of ovarian cancer, and there are some genetic causes of premature ovarian failure that may affect not only their sisters, their mother, but also their father. And that genetic testing ought to be considered. The reason for that is if their sister carries the same premutation for something like Fragile X, they may also be at risk for premature ovarian failure or POF. It's possible for patients to also inherit that gene from their father, and the reason that it's important, their father obviously is not worried about ovarian function, but carrying that gene may put them at risk for an uncommon neurologic disease which affects men after the age of 50. Women with premature ovarian failure have about a 5 to 10% chance of becoming pregnant. We know that about 25% of women will have sporadic ovulation once the diagnosis of premature ovarian failure is made. Unfortunately, there are no tests for us to be able to know when a woman is going to ovulate because it is sporadic. When the diagnosis is made, it's often devastating. So there are a couple of things that are important health-wise. First off, we need to deal with the issues of low estrogen levels. So one of the things that we think about is calcium replacement. Women with premature ovarian failure may have problems with osteoporosis, which essentially is a thinning of the bones. The other thing that we need to think about is hormone replacement. And when we talk to women with premature ovarian failure, there's a lot of scare and a lot of concern with issues with hormone replacement in menopause. In this case, with our women with premature ovarian failure under the age of 40, we truly are replacing hormones because most women under 40 will still be having ovulatory or ovarian function and they will be producing estrogen. Without the estrogen, patients are going to have symptoms that we've discussed, such as hot flushes, mood swings, vaginal dryness. Other things that patients need to recognize is that there is a chance of pregnancy. If you don't want to become pregnant, don't think, patients with premature ovarian failure, they need to recognize if you don't want to be pregnant, you need to use an effective contraceptive. And the other issue is that this is often devastating to women because their chance of pregnancy is significantly decreased. The chance of getting pregnant and successfully delivering a child is excellent with treatments such as in vitro fertilization with donated oocytes. There are many options available to women with premature ovarian failure with respect to having a child. 5 to 10% of women with premature ovarian failure may get pregnant on their own. With in vitro fertilization and donated oocytes, the pregnancy and delivery rates are excellent. Of course, patients may always consider adoption as a way of developing a family, or patients may simply decide that they want to live child-free. There are multiple support groups that can be found online for premature ovarian failure.